Yeah. So first is limb lead, second is chest lead. So in limb lead, we calculate rate, axis, normal sinus rhythm, P wave, PR interval, Q wave. For taking care of calculation of axis, we choose lead 1 and AVF. And for P waves and PR interval, we choose lead 2. So technically, we see Q wave normally in lead 3. So what is the relevance of lead 1? Axis, lead 2, P wave and PR interval, and Q wave as lead 3. Please make it slideshow mode. Yes, I will. I have to change the slide. That's why Dr. Koteshwar, I'm taking this time so that when I come to the main slideshow which I want to, I'll go ahead with it. Thank you. So heart rate, when we calculate heart rate, there are two ways. First is if we calculate with the millisecond, then it is 60,000 divided by RR interval in millisecond. One small box is 40 millisecond. When we talk about box method, it is 300 divided by number of boxes or 1500 divided by small boxes. This gives us a fair idea about what is the heart rate. When we talk about axis, normal axis in calculation of lead 1 and lead AVF, high normal RA rhythm is considered as normal, low RA rhythm is still considered as okay. High LA and low LA rhythm in P wave is never okay. When we talk about, for sake of an example, here we see that in lead 1, P wave is positive. In lead 2, in lead AVF, we have lead P wave as negative, P wave as positive. Thus, we will have a wandering an axis which is abnormal, low RA axis. When we talk about QRS axis, then we should always remember that normal axis from 0 to plus 90 up to 120 is considered as normal, and 0 to plus 180, that is right axis, is still acceptable. Left axis deviation in pediatrics is not acceptable. When we talk about excess in form of calculation, why I'm rushing it? Because we have already done it in last session. For those who haven't joined it, we will be able to understand with this short brief presentation which I'm doing right now. Lead 1 and AVF, if normal we see from 0 to 120 is considered as normal axis. From normal axis, if it is northwest axis or superior axis, that is left axis deviation, it is considered as abnormal. As a dictum, QRS should never be negative in AVF, because if QRS is negative in AVF, we will be having left axis deviation. If QRS, cumulative QRS, is negative in 1 and in AVF, we are going to get left axis deviation with northwest axis, which is definitely abnormal. Where do we see left axis deviation in pediatrics? In AV canal defect, partial or complete, in tricuspid atrasias, in WPW syndrome, single ventricles, left anterior hemiblocks. Normal sinus rhythm. What is normal sinus rhythm? That is normal P wave axis, that is low R, that is high RA, positive P axis in 1, positive P axis in AVF. Every P should have concurrent QRS. There should be a fixed P wave morphology. There should be a fixed PR interval. For example, once we go with an ECG, we check for speed, we check for calibration, we go to lead 1, we check for P wave positive, we check for QRS, we P wave as negative. Here, once we have found it that it is negative, we see that AVF is negative. The P axis, when we say normal sinus rhythm, no, it is not a normal sinus rhythm, because the P wave axis is towards low RA rhythm, and we cannot label it as normal sinus rhythm ECG. Similarly, here we see that P wave is positive here, P wave is negative on in AVF in first QRS complex, P wave is positive in second QRS complex. We can label it as wandering pacemaker. These are important findings to define about arrhythmia and help us tell what and how bad patient will progress if we do not intervene correctly with right medicines. What else we calculate? P wave as a dictum, 2.5 into 2.5 is a normal P wave, that is breadth 2.5, height 2.5. If more than 2.5, we tell it as P mid-trail. If length is more than 2.5 square, then we tell it as P pulmonale, defining as right atrial enlargement or left atrial enlargement. In ECG, again, we have to check on lead 2. So lead 1 and lead AVF are for P axis, and then for QRS axis, lead 2 is for PR interval and for P wave morphology. When we talk about PR interval, it is normally, regardless of the age, 2 to 4 small square, that is 0.8 to 0.16. When it is prolonged PR interval, although it is very common in ASD or repaired tetralogy of fellow, but if it is more than 4 square, then it is prolonged first degree AV block. Shorter PR interval is seen in WPW and Pompe. Today we are going to read about WPW and we will learn more about it. Q waves, one important aspect we should always see for lead 3 to check about Q waves. It is normally seen in inferior leads. It is 1 box wide and 5 boxes in height. If it is abnormally seen in lead 1 or AVN, we are dealing with Alcapa, that is anomalous origin of left coronary artery from pulmonary artery. Wide, that is more than 1 box wide, it is infarction. If it is deep, that is more than 5 boxes, then it is left ventricular hypertrophy. Coming to chest leads, T waves is what we have to check on V1 and V6. RS R' pattern on chest leads, R and S differentiation of height to define about hypertrophy, ST segments to check to tell about depolarization and repolarization, and corrected QT interval. So T waves, we have to see and we have to understand that V1 and V6 will have positive T waves in less than 1 week or in adolescent, and if in V1 if from 1 week to adolescent, V1 will have a negative T wave. When we talk on chest leads, this is what we are this is a normal T wave, where we see that at isoelectric point T wave is normal and here it is negative. For 3 months, T wave is negative, T wave is positive. For 6 years, still negative, positive. But when we reach up to 15 years, it is positive and positive. So a negative T wave in V1 from 1 week to adolescent is considered as normal T wave. Positive T wave in V1 for 7 months is suggestive of right ventricular hypertrophy. And if we see, there is a corresponding negative T wave in V6. So T wave with right ventricular hypertrophy will have exact opposite of what is normal. RS R' pattern, we see a typical R with a small positive deflection from isoelectric line, negative deflection of S, and second positive deflection of R1. We have to check in V1 to comment upon RS R' pattern. We take into consideration the duration of QRS to think about right bundle branch block, or if at all it is incomplete right bundle branch block, complete right bundle branch block, or right ventricular hypertrophy. When we see lead 1 in V1, it gives us abundant of information with a positive deflection of R wave, negative deflection of S, and another positive R wave is suggestive of RS R' pattern, which if duration is less than 0.08, we check height of R dash. If it is less than 10 mm, then we have to more evaluate further. If it is more than 10 mm, then this R wave is because of right ventricular hypertrophy. When duration is 0.08 to 0.09, that is two smaller squares, then it is incomplete RVB. If it is more than 0.09 second, then it is complete R right bundle branch block. The rationale behind this is the atria depolarize ventricle by spread of the wave from sinus nodes, and left ventricle is depolarized first through septum. It goes to the right ventricle, and if there is right bundle branch block, we get R dash pattern. Again, we will see that in V1, we can see that the height of the wave with R dash, RS, R dash pattern with QRS prolongation of more than 3 square 0.12 second, suggestive of right bundle branch block. With R and S height in V1 and V6, we define about left ventricular hypertrophy. If we have S1 or R6 more than 98%, it is left ventricular hypertrophy. When we have this, will keep other things simpler, because left ventricular hypertrophy need to be identified to know about after load increment, which is generally seen in hypoplastic left heart syndrome or coarc or associated aortic stenosis. ST depression or elevation in more than 1 month, more than 1 mm is such a, in a 2-day-old child, is considered as abnormal. And when we see the last step which we check on chest lead is QTC. I'm not going to go in QTC because now we are going to move towards what for today's primary session, which is more clinical abnormality which are usually seen in clinical practice. Going ahead, yeah, right. First is hyperkalemia, which most of us have which most of us have come across in our clinical practice. So hyperkalemia is defined when serum potassium is more than 5.2 millimole per liter. Although the ECG finding will not be seen till the level is more than 6 millimole per liter, and earliest manifestation of hyperkalemia is increase in T wave amplitude. So what is peak T wave? Yeah, ECG features of hyperkalemia. ECG features of hyperkalemia are peaked T wave. There is P wave widening, followed by flattening, followed by PR prolongation. If we do not intervene, there will be bradyarrhythmias related to sinus bradycardia with high-grade AV block, leading to conduction blocks, bundle branch block, QRS winding with bizarre QRS morphology. These cutoff levels at various levels we are going to see. Let us see with the ECG. To remember, push and pull effect. When we see hypokalemia, we see a push in isoelectric pattern, where we see the T wave from isoelectric line, there will be a depression in T wave with a prominence of U wave, and ST is depressed. ST segment is depressed. We are going to talk about J point in upcoming slides. So at this junction, we will see ST depression, we will see T wave inversion, we will see prominent U waves. In comparison to this, when we talk about hyperkalemia, slides are not, I haven't moved the slide. Okay. So hyperkalemia, we see peak T waves, which in comparison to QRS will be taller. We see that P wave flattening will be there. PR prolongation will be there, which is more than which is more than 2 to 3 small squares. Wide QRS complex will PR prolongation will be there. Wide QRS complexes will be there when we deal with hyperkalemia. So as a dictum, hypokalemia pushes the T wave, hyperkalemia pull the T wave. Is it visible now? Kindly comment. No. Okay. Is it visible now? Still not visible. Okay. Am I audible to all of you? Audible, but not visible. Okay. No problem. Let me just because it's an important slide to. So I'll log in with another device and we will see slide 68 is visible. Okay. I think I have figured out what has happened. Just give me a second. Yeah, just give me a second. I think it is visible now. Yes. Okay. So let me just go back and I'll take you again to the journey. Yeah. So now we have hyperkalemia. When we talk about hyperkalemia will pull the T waves. Hypokalemia will push the T waves. When we talk about hypokalemia, level less than 2.5 will have these manifestations. Level more than 6 will have T wave flat, peak T wave. If we do not, please make it presentation mode. Okay, boss. Yeah. So in hyperkalemia, the T wave is pulled upward. It creates a tall tented T wave in comparison to QRS in height of R. In comparison to that, the T wave will be taller. When we see there will be flattening of P wave if we do not pick peak T wave and we do not catch hyperkalemia. Now we will see there will be absence of P wave. There will be prolongation of PR interval and resulting in poor conduction through AV node. There will be broadening of QRS complex. So PR prolongation, wide QRS complex, peaked T wave with P wave flattening is characteristic of hyperkalemia. When we are dealing with hypokalemia, there will be T wave inversion, ST will be depression and prominence of U waves. If you see U wave is this, but we write it U wave, we do not have to look for this, we have to look for this. So hypokalemia will push, hyperkalemia will pull. When we talk further, it is easier to remember this way that whenever we are dealing with hyperkalemia, we have to identify at the stage when we can see tall T. So in this ECG, yeah. So in this ECG, sorry. Yeah. So there is in lead 2, like we have just now read, in lead 2, we have to see that there is a prolongation of PR interval. The difficult part in usual ECG is to identify where is R. So there is a broad bizarre QRS complex. They will be merging. This is a broad and bizarre QRS complex. This entire complex is actually merged with preceding P wave. So QRS complex is merged with P wave and subsequent T wave merging is also being seen with a peak of T wave. If you see, the patient had a potassium of 9.3 in this child, and on long lead 2 we can notice that there is a sine wave pattern. So if we have a sine wave pattern where we have a graph going up and down with bizarre QRS complexes and relatively T wave is merged, then definitely we are dealing with very high potassium level. In comparison to this, when we check on the next ECG, we see that there are tall and peak T wave. If you see on lead 2, we have to check on P and QRS complex. So PR interval is more. We have tall T, which is tented more than QRS complex. They are symmetrically peaked. We can see the symmetry. The patient had serum potassium of 7.0. When we see this ECG, there is prolongation of PR interval. Why? Because there is a positive deflection of P and we have a positive deflection of R and QRS with a tall T. Again P, QRS, tall T. In when we started the presentation, we have mentioned that we take lead 2 to check for P wave, to check for PR interval, and if we talk about PR segment, if we have undiagnosed potassium and it is beyond 9 point and it is beyond 6.5, then we are going to see these pictures of prolonged PR interval followed by wide and bizarre QRS interval. All this is because there is hyperpolarization happening at AV node, and this is going to, if not reversed, this is going to have LVBV blocks which will be visible with RS reversal W pattern on V6, left axis deviation, like we have mentioned in this ECG. So in this ECG, when we see AVF, we can comment that the axis is left deviation is there. There is absence of P wave. When we want to see P waves, we are not able to see any P wave in lead 1 or in AVF. So absence of P wave, left axis deviation with broad complex rhythm with atypical LBB, potassium is 9. This is bizarre QRS complexes in hyperkalemia. In lead 2, again we can comment a positive deflection of R with another tented T wave, that is hugely peaked T waves. On chest lead, we can see how huge the P waves are. Typical sine wave appearance. In the first ECG also, it was typical sine wave appearance. This patient also has hyperkalemia of 9 secondary to rhabdomyolysis. Now, what is the management when we when we see a case of hyperkalemia? First step is stop all potassium supplementation, all medication which are containing potassium or can cause increment in potassium. Start the patient on cardiac monitoring. Also, ensure that if the history is not compatible, you recheck the venous sample. If patient is asymptomatic and ECG is normal with potassium of more than 6 to less than 7, start with salbutamol nebulization. Make insulin glucose perfusion. Start it IV. Give Kexalate per rectal. Bicarbonate if there is metabolic acidosis, because that is again going to increase potassium. If patient is unstable or there is clinically abnormal ECG, make sure that you have anticipation and plan to dialyze if patient is not in a state of hemodynamic stability. Immediately give IV calcium gluconate for membrane stabilization, salbutamol nebulization for mobilization of potassium into the cell, insulin glucose again for mobilization of potassium, bicarbonate because it will make metabolic acidosis environment into normalization and will prevent increment in intracellular potassium level. Per rectal, you have to consider potassium K bind and K oxalate. What is the work of various component which we choose in managing hyperkalemia? First step, when we are in ICUs, we start the patient on hyperventilation. This causes respiratory alkalosis. This drives potassium into the cell, but we are not removing potassium from the body. Second step, which all of us do, calcium gluconate, 30 to 100 mg per kg, stabilizes the membrane cell potential and it causes prevention of severe ventricular arrhythmia. If you see, when we deal with a cardiac arrest in our emergency department, we tend to give as per norms, we are supposed to CPR and adenosine, but we also choose bicarb, we also choose calcium. These do not have any say when we are dealing with PALS protocol. But if we see the reversible causes of pulseless electrical activity, then hyperkalemia is managed with calcium gluconate and bicarb also. So any patient, if you feel that there is renal compromised state or there was a state of shock and there is a chance of hyperkalemia in a VBG, or if you are anticipating, then considering hyperkalemia as a cause, reversible cause of PEA, you can use bicarb and calcium gluconate. When we make insulin glucose drip, again, here we should remember that this is also going to push potassium intracellularly. Adding dextrose in the insulin syringe is not to push potassium intracellularly, but to prevent hypoglycemia. How can we make it? By using 50% dextrose, 1 cc per kg, and diluting it with insulin 0.1 unit to 0.2 unit per kg IV. Slowly you have to give it. Inhaled albuterol is again going to increase potassium uptake by the cell and decrease extracellular potassium. Intracellularly, it will push the potassium. You can give it a trial of furosemide, which is a loop diuretic to increase elimination of potassium, and Kxalate 1 to 2 gram per kg per rectally to bind. Resin bind to potassium in intestine and promote excretion. We are going to take all the questions after the session, sir. Now, when we talk about QTC prolongation, this is another set of problem which is commonly seen, that is drug-induced QT prolongation. There are various common drugs which are being used in pediatric practice which have this side effect, and the T wave usually in QTC prolongation. For example, in case of hypocalcemia, which is very commonly seen, the T wave will remain unchanged. Dysrhythmias are very uncommon in pediatric, although still atrial fibrillation are reported. If we do not correct QT prolongation and the cause of QT prolongation or hypocalcemia is associated hypomagnesemia, then torsades is very common. And we should also remember that torsades is one etiology where we have to identify. Otherwise, our intervention will not work. For sake of an example, when we see a normal T wave with PR interval with QRS complex, when we compare it with hypocalcemia, you can see the morphology of T wave is unaltered, but QT has increased. From QT, you can see that QT has increased. In this, it is decreased. So in this one visual impression, we can see that hypercalcemia decreases QT interval, hypocalcemia increases QT interval. What is corrected QT? Corrected QT is when we correct it with in context with RR interval, we take it to generalize to apply the relevance of calculating QT by ensuring that we calculate it in comparison with every RR interval. Yeah. So in this patient, when we calculate QT interval, we have to see that QT prolongation is calculated in lead 2. As a dictum, QT should not be more than half of RR interval, and there are very good calculators like MD calculator as an app is a very good way of checking these QT interval. Specifically in this example is just for the sake of telling you that how to see QT interval. When we talk about smaller squares, we start from the T, from QRS interval, from Q wave to the end of T wave. Each small square will be 0.04 second, and which is equal to 40 millisecond. So here, when we see smaller squares, 10 smaller squares, 3 more, and another 3 more, so 16 smaller squares. So when we see as QT, it will be 16 smaller squares, 16 into 40 divided by under root of RR interval, which is again calculated by this. Calculations are very tedious, but they are equally very important in emergency setting. My recommendation is, if you have a thought while looking at long lead 2, you see that Q wave or the QT interval is approximately half of RR interval. Rather than jumping on calculating square by square, take number of square and use MD calculator. It will save you more time and you can use that time to review. If you want to calculate, then on ECG you have to calculate RR interval, as under root of RR interval will be needed to divide the QT interval to tell you corrected QT. In this image, we can clearly see that from one R to another subsequent R, we have to calculate all the small squares. This is the time taken for repolarization of ventricle. And from the start of Q wave to the end of T wave, from the start of Q wave to the end of T wave is the time when entire ventricular depolarization and repolarization has happened. So when you want to calculate this, you see that in usual format, if this is a normal ECG, QT is less than half of RR. But if you see the previous ECG, QT is nearly half of RR. This gives you a visual impression of some abnormality in QT interval, where you can go ahead for corrected QT interval calculation, and you can do evaluate this patient for long QT syndromes, other causes of QT interval as well. So in this, when we say in a structured way, QT interval is measured in either in lead 2 or in chest lead V5, V6. We should always remember that longest measurement should be used. We have to take successive beats so that we can take the maximum interval which has been taken. When we calculate, there may be a possibility that large U waves which are being formed are fused with T waves. We need to include them. If we have a smaller U wave and they are separate than T wave, we can exclude them. By that, I mean to say, when we are calculating QT interval and we have a U wave, we take the maximum slope. If we have a prominent U wave, we will include it. If we have a smaller U wave, which is closer to isoelectric line, we are not going to take slope. Rather, we are going to take this intercept in this tangent to calculate QT interval. If the merge of U wave is halfway with the T wave, we are going to take it into consideration, and this will be used to calculate the QT interval. This is very important because U wave or corrected QT interval, if your primary numerator is not calculated correctly, you are not going to get right information and you may miss the patient on diagnosing any kind of etiology. Why it is important? Because if you miss the detection of patient, there are high chances that this patient may die of arrhythmia. And like I mentioned, corrected QT interval gives you a standard calculation of QT interval with a standard heart rate of 60 beats per minute. This allows the comparison of QT values over time at different heart rate and improve detection of patient at increased risk of arrhythmia. Usually, short QT is less than 350, in male more than 440, in female more than 460. As a thumb rule, again I will reinforce that a normal QT should be less than half the preceding RR interval. So apparently in this patient, again we have a QTC prolongation. So lead to V5 or V6. In lead V5 or V6, we can see that QT is nearly more than half. Here, if we calculate, it is apparently 500 millisecond. There is prominence of U wave. So prominent U wave in precordial leads. This patient is a patient of hypokalemia. When we started our presentation, we mentioned that in hypokalemia, from isoelectric line, ST depression will be there, T wave will be pushed, U wave will be visible. So here we have to take a tangent considering U wave is part of T wave and QT will be calculated. Hypokalemia causes apparent QTC prolongation in limb leads due to T and U wave fusion with prominent U wave in precordial leads. These are precordial leads. These are chest leads. So I have tried to explain you where is the merging of T wave and U wave happening in context with potassium. My suggestion over here is to save time on QT prolongation. Whenever you are looking at lead 2, make sure you see QT and compare it with RR. I compare it with RR. So if QT is half or more than half, then you have to check corrected QT. If QT is less than 50% and history suggestive of syncopal attacks or history of sudden cardiac arrest in family, then you again have to calculate corrected QT. If it is not nearly 40% of RR interval, then you can go ahead and check for other causes. Here again we have to see for lead 2, we need to see how U wave have formed in hypomagnesemia. Torsades is a possibility if we do not correct the hypocalcemia secondary to hypomagnesemia, and at this stage hypomagnesemia is associated with long QT. Anyone will identify that ST depression with involvement of U wave is there. We take this as a tangent, we calculate the QT interval and we identify the cause of corrected QT interval. Again, ST segment, there is prolongation secondary to hypocalcemia. T wave is unchanged, but we all can see that although T wave is unchanged, there is no U wave available, but QT prolongation is there. So calculating RR and taking a visual impression of tangent, dividing the isoelectric line and starting from Q, the end of T give us an impression of ventricular repolarization, that it is taking longer for ventricular to repolarize. That means we have to see the cause of prolonged QT interval. In this case, we have severe hypothermia, which is another cause of QT prolongation. When we have calculated, there is broadening of QRS complex over here, more than 2 to 3, more than 4 squares actually. 1, 2, 3, 4. So 4 squares of QRS complex followed by prolongation of QT. So QT, corrected QT is 620 millisecond in severe hypothermia, and it is often associated with bradyarrhythmia because of slow atrial and Osborne waves, and shivering artifact will also be seen. Like this is shivering artifact, this is shivering artifact. These will also be seen in cases of hypothermia. Similarly here, when QTC corrected interval is checked, with widespread, there is a R wave, positive deflection, with J point inflection, with negative T wave inversion, and this child is a typical presentation on ECG with subarachnoid hemorrhage. Sudden rise in intracranial pressure due to subarachnoid hemorrhage can have this characteristic T wave changes. These are also called as cerebral T waves, which are widespread with deep T wave inversion and prolongation of QTC. So if you see, the T wave inversion is present with prolonged QT interval. History is suggestive of head trauma. Relevance of getting an ECG in a child with head trauma is to check for QT prolongation with relevant T wave changes. In this, you see QRS complex is not abnormal, but this is the case of congenital long QT syndrome, because these long QT, congenital long QT syndrome, are because of disorder in iron channels which lead to long QT. They are also known as channelopathies, and they make the patient more prone for torsades and thus ventricular fibrillation and thus sudden cardiac death. Now, let us talk about J waves. So, when we see a QRS complex, the point where S come to isoelectric line is called as J point. From J point, the segment till T wave is called as ST segment. When we see that at J point, the Osborn wave, that is the J wave, is a positive deflection which is seen at the J point in the precordial and true limb leads. It is most commonly associated with hypothermia, like we have seen in the previous slide. There will be reciprocal negative deflection in AVR or V1, which are limb leads, and chest lead, which are looking at the right side of the body. And if you see, this positive deflection is called as J wave, which is seen at the J point, and whatever happens with ST elevation, with ST depression, if we have a positive deflection after T wave, like Q, R, S, and then a positive deflection, this is the Osborn J wave. If we have a J point, that is at the point where the S converts and the start of ST segment begins. This patient is having temperature of 32.5, and we can see that after a S, we have a positive deflection of Osborn wave, and if we have a QRS, then there is definitely QTC prolongation also. The height of J wave is directly proportional to degree of hypothermia. In this case, we can easily see that in precordial leads, we have S and a positive J wave. This is hypothermia, which is moderate, temperature is 30 degree. At J point, we have a positive deflection. This positive deflection is called as J wave, also known as Osborn wave. In moderate hypothermia, 28 to 30, again we can see the height of J wave is corresponding with the temperature patient is having. So submersion injuries, probably you will be seeing J waves in hypothermia. In this patient, temperature is 26 and prominent J wave after T wave inversion is seen. Some people might get confused in the initial phase as RS, R dash pattern. Here I would like to say, to compare the width of morphology of J wave in comparison to R wave, there is a significant difference in peaking. So when we talk about left ventricular depolarization, R is sharp, then repolarized, and because of RBB block, there is another right ventricular depolarization which give us a sharp R wave. Here we do not have a sharp positive deflection, and thus this is the J wave. And we should also see that we have a positive J wave in lead 2. Relevantly, in AVR we have a negative J wave, and in V1 we have a negative J wave. So these are reciprocal finding of negative J wave in those leads. Here in AVR it is not very clear. In AVR there is a negative J wave. In V1 there is a negative J wave. In comparison to it, we have positive J waves in lead 2, lead 3, which are more towards the left side of the body. Many of us come across this news of sudden cardiac death in someone while dancing, while playing. More or less, we have heard about many relevant, many known personalities having sudden cardiac arrest. Brugada is one of the syndrome which is associated with the high incidence of sudden death in patients who have structurally normal heart. It is due to mutation in cardiac sodium channel gene, and thus it is often referred to as sodium channelopathy. When we talk about Brugada, type 1 is one which we have to discuss and we have to identify. So when we talk about type 1, the ST segment, which I explained to all of you just now, when we have a PR wave, S wave, S wave reaching to isoelectric point, and this coving of ST segment, an elevation of more than 2 mm in V1 or more than 1 mm. 1 mm, what is 1 mm? This is 1 mm. More than 1 mm in V1 to V3, followed by a negative T wave, is the typical pattern seen in Brugada. This is typical finding of Brugada sign, which if is noticed by anyone at any age, this patient will need intracardiac device for taking care of his arrhythmia. These are usually associated with following clinical criteria to make the diagnosis of Brugada syndrome. That is, there is a documented ventricular fibrillation or polymorphic VT. What is polymorphic VT? It is Tosades, where there is a family history of sudden cardiac death at under 45 years of age. We have COVID ECG finding in other family members, and syncopal attacks is a common history, or in the night there is agonal respiration as a history being noticed by other family members. Such patients are type 1 Brugada. There is type 2 and type 3 also. In type 2 Brugada, the ST coving will be more than 2 mm, and it will have a prolonged saddle shape, and T wave will not be inverted. It will be, this is the saddle shape with T wave normally elevated, not inverted. In Brugada type 3, there is morphology of type 1 or type 2, but this coving will be less than 2 mm, and these are typically not very prominently considered as problematic. Type 1 has more associated abnormality and should not be missed if at all you come across such ECG. Most of us who have been working or are doing any kind of physical activity are now being asked to go ahead with the ECG. Brugada type 1 sign is one thing which you should watch in ECG done on age less than 45 year of age. Adolescent definitely 30 to 40. If you are doing it for yourself, then Brugada sign is one thing which you should look for. This is cross test sign, where you see that there is a notch near the apex of R wave, mainly seen in the inferior lead, that is 2, 3 AVF, and it is usually seen in large portion of patients who have ostium secundum atrial septal defect, which is the most common form of atrial septal defect. Again, you can see the peaking of right bundle branch block is the cause behind it. In lead 2 and in AVF, it is very typically seen. In lead 3, once you look at it, there is a small peaking, and in this waveform, you can appreciate crochet sign. There is this characteristic R wave notching in inferior lead, that is lead 2, 3 or AVF is crosscheck sign. There is slight right axis deviation, and there is evidence of right ventricular hypertrophy and incomplete right bundle branch block with QRS duration between 0.08 to 0.09 seconds. In this ECG, you can see that there is right axis deviation. There is crosscheck sign in lead 2, lead 3, and in AVF. So when you see such cases with ECG in a 3-year-old, ASD should be at the back of your mind with associated bundle branch block. And in the previous ECG, we have noticed in lead 2, lead 3 in AVF crosscheck sign. After surgery, there is resolution of crosscheck sign in lead 2. There is still presence. In AVF, there is marked improvement and reversal of crosscheck sign after complete repair. WPW syndrome is one thing which all pediatricians have thought of, heard of, and sometimes dealt with as well. So WPW syndrome is characterized by occurrence of SVT, plus there is specific ECG finding in sinus rhythm. There is characteristic pre-excitation which is evidenced by short PR interval and wide QRS. With upstroke of QRS, there will be slurring, which is also noticed and said as delta wave. Now, what is this? In this, there is antidromic AV reentrant tachycardia, 5-year-old. We can see that we have a broad QRS complex. And when we talk about broad QRS complex, it is more than 4 small squares. Each of us can mistakenly say that this can be VT. We should always remember that in pediatrics, more than 95% of broad complex tachycardia are SVT with aberrancy. That is, in less than 1 to 2 years, possibility of WPW is very high. And they usually cause antidromic and atrioventricular reentry tachycardia, and they are the cause. What is this upslurring? So after reversion to sinus load, we can see that there is very small PR interval. It is actually less than 100 millisecond. That is less than 2.5 square small squares. So one square is 40 millisecond, one small square. And if you see, there is upslur in the stroke in QRS complex is not sharp, but there is this upslurring. This slurred upstroke to the QRS complex is called as delta wave. In contrast to WPW in adult, the QRS complex in children is not wider. It is not more than 80 to 100. It is not more than 2 to 2.5 squares, but duration is reasonably normal QRS duration. But there is typical slurring at the R wave, and this R wave upstroke slurring is called as delta wave. If you see, similarly in AVL, we will be looking at Q wave, which is simply an inverted delta wave, because AVL tells us about the left side of the heart, and in this case, when we see lead 1 and AVF, we have P axis in high RA rhythm. When we see there is a negative QRS axis, that is in the rhythm, the right axis is plus 90 degree. When we see in V1, we can see R, S, R dash pattern. Duration is 0.08 to 0.09. That is R dash R pattern in V1. Subsequent T wave inversion in V1. If we see the age, it is T wave inversion from 7 days to adolescent. In V1, it is normal. R dash, RS R dash pattern is definitely seen, and we have to check for WPW in this child. So short PR interval, presence of delta wave, mild QRS prolongation or no prolongation of QRS, right axis deviation, dominant R wave, in V1, and inverted or biphasic T waves in V1 or V2. These are kind of normal finding in pediatrics. But when we have this finding with short PR interval along with delta wave with slight QRS prolongation, we should be evaluating these patients for WPW syndrome. With this, we have covered some of the atypical clinical findings along with very common clinical ECG findings for pediatric patient. In case any doubt you have in hyperkalemia, in Crochet sign, in QTC prolongation, in hypocalcemia, hypomagnesemia, hypothermia, what is J point, what is Osborne J wave, what is WPW syndrome, what is delta wave, then you can put in the questions on the chat box. In case you have come across certain other cases and you want me to discuss ECG findings on those, then also put in the chat box. I'll ensure that we cover in a special session of pediatric ECG made easy, and this series will be available as for free access to all webinar on ECMS channel. With this, if at all you have any questions, yeah. So crochet sign is I'll just show you the crochet sign that will make things easier for me to explain. Yeah. So okay. Give me a second. Yeah. So when we see that in ASDs, crochet sign signifies a upslur in right in R wave when the depolarization is ending in the ventricle, and it is suggestive of, it is usually seen with second ASDs, mainly which are big, which are second, which are causing right ventricular overload, because muscle has to work more. There is associated stretching of right ventricle. Because of that, there is dissociated depolarization, and we see a typical positive notch in the inferior leads, that is lead 2, lead 3, and in AVF. When we see cross-test sign, like in this case, we have seen cross-test sign in lead 2, not very clear, lead 3, and in AVF. Once we have operated them, we see that there is improvement in cross-test sign. Clearly, it is gone in AVF. Some faint evidence is present in 2, and in 3 it is not very clear, but the same defect because of filling secondary to ASD, usually seen with ASD with volume overload, we see this typical sign which is named as cross-test in cases with ASD, and once it is corrected with intervention, we see recovery from cross-test sign as well. Okay. Resonium, is it available safety? No, Resonium is not available in India. Basically, Kexilate, yes, it is available. And in one question, one of the doctor has asked about neonatal What to use in neonate in case of hyperkalemia? Yes, salbutamol or glucose insulin, bicarb, all these modes are to push intracellularly, potassium to be pushed intracellularly. To remove potassium from the body, dialysis definitely is very useful if there is hemodynamic compromise. If not, then Kxalate as Kxalate resin is useful. And in newborn, you need to be very cautious. It is dependent on unit work, how they have gone ahead, and involvement of cardiologist and nephrologist will be better because associated complication in smaller preterm with giving them per-rectal Kxalate also should be considered when you are comparing doing a PD to take care of potassium versus Kxalate in a child with NEC. So that is purely a clinical decision, and there is no straightforward no to any of them, but it depends on how your unit practices and what are you more comfortable with, what is your personal experience or your unit experiences. With this, as there are no more questions, we will be closing this session, and it was great to have all of you today. I hope you have enjoyed this session. The recording will be shared on ECMS Talks. Most of the session, sir, can you throw more light on hyperkalemia treatment with dextrose and insulin? Yes, definitely. So, Dr. Saab, hyperkalemia treatment with dextrose and insulin is primarily the role of insulin to push dextrose or to push potassium into the cell. Dextrose is given with insulin to prevent hypoglycemia secondary to insulin infusion. If in a child of let's say 200 sugar, you give them 0.1 unit per kg of insulin, then they are bound to get hypoglycemia. Why? If you remember DK protocols, when sugar is less than 200, acidosis is not resolved, you add dextrose. There, because you know the cells are not going to take glucose, you add 5% dextrose. And with 0.1 unit per kg of insulin, you try to bring down acidosis and you try to take care of DKA part. But you bring in dextrose to prevent hypoglycemia there also. And when you talk about hyperkalemia, then insulin is going to push potassium into the cell. Beta agonist salbutamol is going to push potassium into the cell. Bicarb, by making environment less acidotic, will again push potassium back into the cell. Because if there is H plus ion extracellularly, they are going to be replaced by potassium, and potassium will be coming out extracellularly is going to harm all the muscles. So insulin, bicarb, and salbutamol, they are meant to push potassium into the cell. Rate at which maximum insulin can be given, especially in neonates. If you are talking about hyperkalemia, then the infusion should not be more than 1 ml per kg, and you have to titrate. That is why you have to take ECG, and it should be a continuous ECG monitoring on your screen. If you are taking, can we calculate the general axis deviation as an adult, or always check the axis of both P and Q waves separately? It is advisable to go step by step, and by default it should not be left axis deviation. That means the QRS axis, there should not be negative. A left axis deviation is never normal in pediatric population. And if you see, there in few ECGs I've shown that P wave has a wandering rhythm. P wave is abnormal. QRS is normal in those ECGs. And to label those children as wandering pacemaker will help you identify congenital sick sinus syndromes or other congenital defects even after post surgery scarring leading to rhythm disturbances. Because of that also, you will be able to identify if you go structurally. So again, I will reinforce, look for right patient, check for age, go for speed, look for calibration, go to lead 1, check P wave, check Q wave. Go to lead AVF, check P wave, check Q wave. Go to lead 2, look for PR interval, look for P wave morphology. Go to lead 3, look for Q wave. If you see Q wave in AVR or AVL abnormal, so 1 block broad and 5 block tall is normal for Q wave. 2 block broad, 2 block tall, normal for P wave. Anything other than this is abnormal. When you go to chest leads, V1 to V6, you can focus on V1 and V6. If you're dealing with V1, then you have to look for RS, R dash pattern. You have to look for T wave inversion. So T wave inversion is normally seen in 1 to 7 days and above adolescent. T wave inversion, T wave inversion is not seen. It is T wave inversion is seen normally in more than 7 days to less than adolescent. And if you see any other finding apart from this age group, then you're looking at an abnormal ECG. Normal sinus rhythm calculation itself is very important. Madam, if you do not look at P wave morphology, you cannot comment upon normal sinus rhythm. So if P wave axis is high RA, then it is a normal sinus rhythm. Otherwise, you have abnormal sinus rhythm. So by dictum, we jump on QRS. Taking consideration of P axis is equally important. I hope I was able to answer your question. Okay. Okay. So most of us have doubts on dextrose and insulin. To close it, dextrose is used with insulin to prevent hypoglycemia. It has no role in treating hyperkalemia. Insulin, insulin bicarb salbutamol. Because of alkalosis, potassium and K plus H plus ion channels will not work. So we will keep potassium intracellularly. To do that, we induce by respiratory alkalosis by hyperventilation, or we give bicarb by infusion to make extracellular environment more alkalotic, so that exchange doesn't happen and we can save hyperkalemia manifestation. If we see any kind of instability, that is cardiac instability in form of hypotension or any kind of other instability like seizure or anything, such cases, if you have noticed hypokalemia, membrane stabilization by calcium gluconate is very important. Membrane stabilization will prevent arrhythmias, and arrhythmogenic cardiac myocyte will cause death in no time. So, Koteshwar sir, whenever you see that height of R wave and height of P wave is equal, you check potassium. Usually, R wave and T wave is like this. If R wave and T wave are like this, or T wave is beyond R wave, it is abnormal. So, by looking at ECG, QT prolongation, you should be able to comment how you see RR, you see QT. T wave morphology, compare it with preceding R wave. So T and R you should see. If you see in this frame also, I will just remove this frame. Here also, if you see, there is T wave which is at half of Q wave in lead V3. But when we go to long lead 2, we can see R wave and we can see T wave. We can see QT, which is nearly 40% of RR. So in one go, we can clearly say that hyperkalemia is not there. QT prolongation doesn't look like. And two major problems we have already removed from the differential part. When we begin in the systematic manner, I'm sure we are not going to miss, because we are going to look at morphology of 1, 2, 3, AVF. We are not going to look more on AVR or AVL. We are not going to look more on V4, V5, V3, V2. We will focus on V1, we will focus on V6. So to have a full understanding of how ECG helps us in getting to a diagnosis, it is a long process. Again, I will request, if at all you have if you have come across difficult ECGs, then you have a diagnosis which you have reached, just share me the diagnosis. I'll make sure that we have a special session on those atypical findings with their typical ECGs, how we can calculate. Out of interest, I have added Brugada, because nearly in last 6 months, every third or fourth day we come across one fine video where somebody is dancing died, somebody playing died, somebody watching TV died, somebody in gym died. So Brugada sign is one thing which everyone should be aware of, one thing which we should be knowing, because if we know that, we are able to identify those who are prone for sudden cardiac arrest, and we can save some lives. With this message, and if there are no more questions, we will close this session. And it was great meeting you all. Have a great day. Have a great week. Take care. Bye bye.